Now, what are the treatment options for this patient? Well, first of all, I'll note that the patient has a typical EGFR mutation. So the typical EGFR mutations are exon 19 deletion or L858R, which is an exon 21. And if you have those two different alterations, the typical EGFR mutations, you've got a number of treatment options. You have first and second generation drugs that are still FDA approved. That's gefitinib or erlotinib as first generation drugs, or afatinib as a second generation drug. Recently, based on the results of the FLORA study, which was a first line study that compared osimertinib versus first line drugs, erlotinib and gefitinib, osimertinib has become a first line option as well. And given that it was superior in that study to the other drugs, I think many people, including myself, will often use osimertinib in the study. Now, the relay results actually offer another potential option for patients as well, assuming this is FDA approved. And recently, the relay results have led to a favorable ruling from ODAC, which often precedes the FDA approval for a regimen. Now, the relay results were as follows. It was a study comparing erlotinib and ramucirumab versus erlotinib alone, or erlotinib with a placebo. And that showed a significantly improved progression-free survival, which was the primary endpoint of the study. So the PFS in that study was 19.4 months as compared to 12.4 months for erlotinib alone. So that's a 7-month improvement in PFS. Now, it's worth noting that in the FLORA study, osimertinib as monotherapy had an 18.9 month PFS, which is slightly shorter than what was seen in the relay study. So if you look head to head with erlotinib and ramucirumab versus osimertinib, that frontline PFS results are really comparable between the two. Now, this may raise the question, well, why would one take an IV drug, ramucirumab, in combination with erlotinib when you could just start with osimertinib? Well, starting with osimertinib is unquestionably still a reasonable treatment option. But I think a lot of people would consider erlotinib and ramucirumab, including myself, in good performance status patients who do not have CNS metastases, because you still have the ability to use osimertinib later. So in other words, if you start with erlotinib and ramucirumab, just about half of the patients then subsequently develop, at the time of resistance, a T790M secondary mutation. And T790M mutations can be successfully treated with osimertinib. That was the original FDA label for osimertinib. So if you start with erlotinib and ramucirumab, one can then move on to osimertinib later. Whereas if you start with osimertinib at the time of resistance, currently there are no FDA-approved targeted regimens for resistance mechanisms that might emerge for osimertinib. You know, those resistance mechanisms are diverse. Work from our group and a number of other groups have shown that patients with osimertinib, who are receiving osimertinib, can develop resistance by a host of different mechanisms. That includes MET amplification. It includes additional EGFR mutations like the C797S mutation or an L792H mutations. It includes PIK3CA mutations. Other fusions like RET fusions have been observed as well, BRAF mutations, and so forth. In fact, there's a whole variety of different resistance mechanisms. And in a lot of cases, the resistance mechanisms can't be seen by genetic profiling. It can be things like EMT. So the reason one may start with erlotinib and ramucirumab is it leaves open the option of osimertinib later if T790M alterations develop. Whereas if you start with osimertinib, you don't have the option of erlotinib and ramucirumab later. How does PD-L1 status factor into the decision making here? Well, I noted that the PD-L1 level, the TPS score was 20%. And for a patient who doesn't have a driver alteration, with the TPS of 20%, you certainly may think about immunotherapy as an option. But I think it's important to note that patients with EGFR mutations do not typically have good responses to immunotherapy. In fact, in retrospective studies, the response rate for EGFR mutant patients to single-agent immunotherapy is typically on the order of 5 to 10%, as compared to a targeted agent, if you've got a typical EGFR mutation, where the response rates are in the range of 60 to 70% typically. So if you have a choice in an EGFR mutant patient between a PD-1 or a PD-L1 inhibitor or a targeted agent, the targeted agent is always the way you want to go to start with. And we typically reserve immunotherapy for further down the line after chemotherapy for patients with EGFR mutation. So if you put those factors together, the fact that it was a typical EGFR mutation, brain metastases were not present, I think the choice of erlotinib and ramucirumab would be a very reasonable treatment option here. Other reasonable treatment options would include osimertinib and the other older EGFR inhibitors, afatinib, gefitinib, and erlotinib, are still FDA approved. But given the recent results of the RELAY study as well as the FLORA study, I would usually think about either osimertinib first or erlotinib and ramucirumab if that regimen is approved.